Hello everyone. I will not be discussing the usual board review type lesions of the corpus callosum. I will focus on some less commonly discussed features of the corpus callosum that we should be aware of in our daily practice, and also be discussing some developmental issues of the corpus callosum. Here's an interesting case. This was a 7-year-old girl with new onset seizures, left hemianopsia, and history of severe sinus disease. The clinicians were worried the possibility of an abscess or venous sinus thrombosis. So she underwent a series of MRS investigation. Anybody see any abnormalities in this? She had a normal diffusion study and a contrast study and a venogram, MRV. Anybody see anything? The post-contrast study showed no abnormalities. The venogram, the MRV showed no abnormalities. There was one finding here, and I told them not to worry about anything, that the findings are long-standing. Anybody sees what I'm referring to? Here's the finding. What is the arrow pointing to? Correct. As Dan says, the arrow is pointing to the splenium. The splenium does not look normal. And the significance of this abnormality I will get into now. Again, even more noticeable on the pre-contrast scan with an enlarged image. Let's talk about the corpus callosum segments. The first segment is the Lamina Australis, which I will discuss in more detail later. We have the rostrum, then we have the genu, the body, and I colored them different arrows. This narrowed area is called the isthmus, and then we have the splenium, as you can see also on the MR images here. Now, the anterior commissure has about 3 million fibers. The hippocampal commissure, which is very tiny, only has several hundred thousands. And in the human, the corpus callosum, which only transmits a portion of the fibers from one hemisphere to the other, has over 300 million fibers. So it's a huge difference in the human between these various commissures, and that's why the corpus callosum is quite significant in size. If we look at this beautiful dissection from above, we see many of the fiber bundles that cross the corpus callosum from one hemisphere to the next. Nowadays, on DTI, we can see in red the body of the corpus callosum, in red because the fibers cross from right to left or left to right. Another important structures are these, the forceps minor and the forceps major, which we can see in green here. The forceps minor connects the frontal pole region with the fibers that go to the genu, and the forceps major are for the fibers that go from the splenium to the occipital lobe, and also some to the posterior temple. And you can see here on this anatomic specimen, this would be the forceps minor and the forceps major. We can also visualize now in DTI the corpus callosum and the coronal, as well as on the sagittal image. Again, the genu, the body, and the splenium. Now, there's been tremendous interest in the topographical organization of the corpus callosum. There was a lot of work done on the rhesus monkey to visualize the topographic organization. And the way they did it is created lesions in various parts of the corpus callosum and then determined the Wallerian degeneration, which areas of the cortex were involved. There also have been injections by various isotopes and various chemicals into different cortical areas to see which tracking led to which part of the corpus callosum. And here's a study also done on a rhesus monkey that shows that topographic distribution, again in the monkey, with the prefrontal area here, the primary and secondary motor area here, and then the somatosensory further back here in the region of the isthmus. And then importantly, this is the area of the isthmus where some of the auditory fiber are, and the splenium for primary and secondary visual region. Now, there's a huge difference between the monkey's brain, as I'll show later, and the human brain. And this was a study done on the human brain where they looked at brains that had small infarcts or small traumatic lesions, and then looked for Wallerian degeneration by histologic examination of the corpus callosum. And they determined, for instance, that in this region here they saw abnormalities in this sector of the corpus callosum, while with occipital infarcts or small lesions in the posterior part of the occipital lobe, they saw involvement of this region of the corpus callosum. Again, there's a huge difference in humans versus the monkey brain, as I'll show later, as far as size and many of the tracks. So again, this is in the monkey brain, and this is in the human. But again, these studies had a lot of difficulties in selection and also in the amount of lesions they could demonstrate. One of the problems comparing a monkey with a human is the tremendous changes in the brain. For instance, here's a primitive mammal, a shrew. You can see that the motor, the visual, and the auditory cortex are all bunched together in the upper part of the brain. However, in the human, because of the tremendous development of association area, these regions are separated quite a bit. So here the motor, somatic, sensory here, visual, and then auditory. And that's all because of the tremendous expansion of the association area for complex activities. And for instance, if you look at this pre-simian brain of, let's say, a lemur or something, here the association areas in white, but in the human, the association areas are tremendously enlarged, and that's why the brain is so much larger. So again, to compare a monkey to a human brain is not exactly very definitive. One other interesting thing that these investigators actually from Yale saw, that the distribution of fibers was very specific to various regions. So for instance, in the region of the genu, there was the highest concentration of small fibers and very few unmyelinated. So different fiber types and the density of the fiber types varied by region, very similar to the topographic distribution. So it was very interesting that each region had different type of fibers for different transmission speed and various activities. Fortunately, now we have DTI with tractography that can be used in the human. And you can see, for instance, here's a map showing the distribution for the various components of the corpus callosum to the various areas, the frontal, parietal, and the occipital, and also for the posterior temporal here. And here's an axial view of the same thing. And amazingly, there's very complicated tractography, and patients with a partial agenesis of the corpus callosum, they actually tracked fibers which did not end up in the expected location. For instance, this was called homotopic distribution, where the fibers go from one frontal area to the opposite frontal area. But they found that some frontal fibers end up in the posterior parietal region. So as DTI gets more sophisticated and tractography more sophisticated, there'll be much more precise topographic analysis of the fiber location on the corpus callosum, and also the variations between populations. People have also used tractography in the region of the corpus callosum to look what happens. For instance, here's a patient had trauma and had hemorrhage involving the corpus callosum, and lower down here we have a normal showing the distribution of the fibers from the corpus callosum to the cortex, and we can see it on both sides of the midline. While in this case, there's a plethora of fibers. Here there's only like one fiber, maybe another one. So there's destruction of the fibers coming out of the corpus callosum or going towards the corpus callosum. Here's another patient that a trauma was contusion and hemorrhage involving the corpus callosum, and again, there's only fibers on one side, but no fibers going. So it's a very useful analysis to look at the kind of damage that occurs to specific fibers. Now, this diagram, which is simplistic, is useful for us to remember because it kind of shows where the various functions that we're interested in are located. For instance, the splenium area is for visual fibers, although the other parts of the splenium which have connections to the posterior temporal region, for us the main interest is the portion of the splenium which is at the center of it, which is involved with vision. The isthmus is where the auditory fibers from Heschel gyrus will cross, and here in the posterior body would be the somatosensory. Anterior body is the motor, and I don't know why they put a question mark, because in the rostrum and the genu is really the higher cognitive function fibers would cross. So now we go back to this patient which I started off with. We can see how all these things can be explained by what happened maybe before birth or during birth or after. We can see here the lesion or some gliosis in the occipital lobe, which explains the visual issues. But notice that because of this amputated appearance of the splenium, that the fibers, was like some Wallerian degeneration that involved the fibers going to the splenium. So this was not an acute finding, that all these findings were chronic for a long time, either prenatal, perinatal, or postnatal. And the patient actually did well, and there were no other issues except the visual, the left hemianomus and hemianopsia. And we can see why here, because of the involvement of the medial occipital lobe. So this was the clue. As soon as I saw this appearance of the corpus callosum, I knew that this was a chronic lesion and the symptoms were not due to anything acute. Here's a patient before and after surgery. What was the type of surgery that was performed here? Can people hear me? What was performed here? Not a lobotomy. Lobotomy is removal of a portion of the brain. There was something was removed, but what is that called? No, not a shunt. Correct. As our resident said, there was a calosotomy. Notice that there was removal of the anterior part of the corpus callosum was cut. However, notice that the splenium is left. Surgeons found over the years that if you also cut through the splenium, there were severe complications as far as the ability to read and to see and to coordinate. So callosotomies are now limited, and usually they're done very rarely now for people who have intractable seizures who do not respond to any type of medical treatment. And although they do most of the time now temporal lobe surgery, this callosotomies are occasionally done for intractable seizures. And again, so everything is cut through except for the area of the splenium because of the severe symptoms involving vision and reading and being able to name objects. So the splenium is left intact. Here's another example from the literature showing that there was a callosotomy here, but the splenium was left intact. And here's a case from Yale prior to surgery, and here we see that the splenium was left in place. There was a little cyst in front, but the surgery involved the anterior part of the corpus callosum. This is a patient that had 2 MRs. This was following 5 years after this one. Anybody see any difference? Correct. There's volume loss. Look, for instance, here, the anterior body is much thinner here, and look at the difference in size of the genu. Even the splenium may be slightly smaller. And we can see why. This patient had severe trauma, and look at the damage involving the right hemisphere here with tremendous gliosis, and so this would involve the fibers that leave this region with Valerian degeneration, and so that's why the corpus callosum looks so thin, which usually people don't comment on it when they read, but that's a definite finding. Here's a case from the literature. Patient post-severe trauma. This is just a normal they put down for comparison, but look the thinness and the loss of all the majority of the volume of the entire corpus callosum. Here's a case we had. Patient had some sort of a congenital lesion involving the left frontal lobe. If we look at the corpus callosum here, it looks kind of normal. Doesn't look particularly abnormal on this projection. If we look at the SAG, I think most of us may pass that the genu looks okay. But this is the value now of tractography which many times we don't pay attention to, and I never see any comments relating to that. But look at the normal. The region of the splenium and the genu and the rostrum should be approximately equal. Look in the patient how much thinner the area of the genu is on the tractography or the DTI compared to the splenium. So this is just confirms that even on the regular MR, when it doesn't look that abnormal, on the most sensitive DTI, we can see that there is a loss of volume of the fibers crossing. Here's another case that we had of an arachnoid cyst in the frontal region. Notice the thinning of the calvarium here, and here's the MR. And if you look at the genu here, it doesn't look too bad. But again, look at the difference on the DTI. Again, the region of the splenium on the normal and the region of the genu. But look at the splenium here and the size of the genu, much narrower. Remember that the fibers change color. The ones that go strictly horizontally from right to left or left to right will be in red. But because of the curvature, you'll get kind of a gradation of color as the fibers go towards the forceps major. And the same thing here, the kind of yellowish color and then green as the fibers from the genu go into the forceps minor. Here's another patient of a recurrent astrocytoma where we see the lesion here. Notice that the corpus callosum in the anterior body looks a little thin, and again notice the difference in size. So again, although nobody seems to comment on this, these images are quite useful to analyze what has happened to the crossing fibers in the corpus callosum. What's wrong in this patient? Anybody? Correct. As Anshu said, no corpus callosum, no red fibers crossing. This is a patient with agenesis of the corpus callosum. So again, normal, no fibers here. And here's the rest of the study, the classic appearance on a sagittal MR, the typical shape of the frontal horn and the ventricle and the axial view. Even an angio was performed, doesn't show the normal curvature of the pericallosal artery. The artery comes straight up because the genu is not in the way. And what are the arrows pointing to? What are the yellow arrows pointing to? What is those structures called? Correct. Again, as the resident said, these are the bundles of probes, or probes bundle, also known as the longitudinal callosal fibers. Remember, when there's agenesis or the complete agenesis of the corpus callosum, that we get these probes bundles, or the fibers kind of traveling from front to back and back to front, trying to cross over any way they can. Some of them will end up in the anterior commissure or in the commissure of the hippocampus. So these are the probes bundle, again in green because of the anteroposterior or posterior anterior direction. And I showed this last time. Here's a normal anterior commissure. Here's a patient with agenesis of the corpus callosum, and notice that the anterior commissure is much larger than normal because of the crossing fibers going through the anterior commissure. And this also I showed last week again. Agenesis was a large lipoma and a larger anterior commissure compared to the normal right here. And again, the last case, agenesis of the corpus callosum and enlarged anterior commissure because of the crossing fibers. And again, tractography is going to really enrich our knowledge of the crossing fibers. Here's, for instance, a normal one, and these are different patients with partial dysgenesis and only partial formation of segments of the corpus callosum. And by tracking very carefully, they show the various connections. A lot of them are not the typical homotopic, but heterotopic, by fibers going from one location to the other. So that's where the future of the tracking of the topography will fill in a lot of gaps in the human anatomy, knowledge of the corpus callosum. Again, showing fibers connecting from the frontal to the posterior parietal region. Very sophisticated DTI. What did this corpus callosum show? Anybody see any lesions? Yeah, the fluid signal in ponds is not why I'm showing the case. High signal in the body could be from a shunt. Anything else? A rare lesion could be MS. That's true. Anything else? Correct. Infarct. Infarct of the corpus callosum are quite rare, but they do occur. This was a small infarct, and this is a study done showing the vascular supply of the corpus callosum. The pericallosal artery and also the posterior branches coming off the posterior cerebral run, and then they provide these perforating branches, they go perpendicular to supply the corpus callosum as well as the singular gyrus. So sometimes, most likely after trauma or bleeds, there will be interruption of these perforating fibers, and you may get a localized infarct, like in this case. So this is like a limited infarct of the corpus callosum. Here's a case we had a number of years ago, and patient came in with a hemorrhage, as you can see on the CT, in the region of the posterior corpus callosum. A CTA was performed, showed an aneurysm coming off the pericallosal artery. We can see the angio here. The patient had coiling, and unfortunately, the only MR were performed post the coiling. This is 2 years post, and we can see that there's thinning here of the corpus callosum, but also interruption of the fibers in the region of the isthmus. And you can see that 8 years post-coiling, there's more significant damage in the region of the isthmus, where we cannot see any of the fibers of the corpus callosum. This is an interesting case. Patient had a stroke involving the corpus callosum and developed stuttering. And it's interesting, kind of a rare abnormality. And again, if we look where the damage is, it's really in the involved the supplemental motor area. And the authors of this paper felt that because of this stroke, there was interruption of the fibers involved in speaking, and that's why the patient acquired the stuttering problem, because of this very localized involvement in the region of the supplemental motor area, which controls some of the speech functions. Okay, this is a 2-day-old infant. What is the problem? Correct. As everybody says, Dan, the resident Cecilia, the reading room down in Fitkin, agenesis of the corpus callosum. So now we get into the topic I want to talk about. Here's agenesis, and here's two patients of one 11 months, 13 months having abnormalities of the corpus callosum. And the question is this abnormal development, or are we dealing with destructive lesion? It's become very important to know from a genetic point of view what exactly has happened. So it's important if we could elucidate what exactly happens in these abnormal corpus callosum with patients. So knowledge of the normal development sequences helps distinguish dysgenesis from destructive lesions. That's the key. What is the sequence of development of the segments of the corpus callosum? As people said, this is what has been written up many times. The corpus callosum normally develops in an anterior to posterior direction. The genu forms first, followed by the body, splenium, and lastly the rostrum. That was for many years, and is still being quoted as and being taught as the correct way that the corpus callosum developed. I'm here to show you that this is totally wrong. Now, why is this totally wrong? Later I'll show some. I got involved in doing a number of dissections on various animals for a chapter I was writing many years ago, and looking at the brains and the corpus callosum on these animals, it made no sense that this sequence was totally wrong. So this genu, body, splenium, rostrum made no sense from an evolutionary point of view. And also, if the genu was the first to develop, the body of the corpus callosum could not be present without a genu. Now, I presented a short presentation at the ASNR meeting showing some animal brains and pointing out that this was not the correct sequence, which was very popular at that time. And the reception for my talk was very negative. I was criticized severely for bringing in animals into the picture, so it was not accepted. However, my colleague Chip Truitt, after the talk, who I didn't meet before, came up to me and said that he believed that my ideas were correct and I should pursue it further. So after a lot of work, I decided to tackle this in a more serious way. Now, why did I have such strong feelings about that idea was incorrect? I'm just showing you 4 animals that I dissected, and this is just the prefrontal region. For instance, in a rabbit, notice the rabbit's brain is smooth, there's no development of sulci or gyri, And in the cat, we have a larger frontal area, a little more prominent, as you'll see in the midline sections, and definitely in the monkey, it's much larger. And if we compare, for instance, the monkey with the human brain, note the tremendous expansion of the prefrontal region. The whole brain is expanded, which I'll talk about in another talk, but look at the prefrontal region. This whole area is filled up. And if we look at the midline cut, what we see here, at the time, we were injecting the ventricular system with a barium gelatin mixture to make cast, and also for it showed up on radiographs. So that's what you're seeing, this gelatin material. But notice, for instance, very tiny frontal pole here and a small corpus callosum, a little larger on the rabbit, and in the cat it's more prominent. In the monkey it's more prominent, and the corpus callosum becomes more prominent. And notice also the difference here in the monkey. We can see a much more recognizable corpus callosum with a genu and a small splenium. But look at the difference in the human. Again, the marked expansion of the prefrontal area, and also the arcing of the corpus callosum because of the marked increase in fibers. You know, the monkey may have about 30 million fibers going through the corpus callosum. In the human, they estimate about 300 million. So there are 10 times more fibers going, and that's why the marked expansion of the corpus callosum. So I decided to tackle this issue on 4 fronts. Once and for all, to demolish the initial theory. I approach it from an evolutionary point of view, embryologic, anatomic, and MR analysis of normal, abnormal regional degenu of the corpus callosum. Now I needed some sort of a landmark to show what happens. And after many weeks of thinking, I came up with what I call the Mack Line. If you draw a line through the mammillary body, anterior commissure, and then continue through the corpus callosum, you will see the genu in front of that line. So I called it a Mack. Being an Apple user, I found it's a nice term. We call it Mack for the mammillary body, anterior commissure, and the corpus callosum. And it's an easy line to draw, and after a while you kind of draw it in your mind as well. So here, for instance, an MR, and again the line going through the mammillary body, anterior commissure, and then through the corpus callosum, genu is in front. Now, what's the rationale using those two structures? The mammillary bodies and anterior commissure are ancient and permanent evolutionary and embryologic structure. They're always there in all mammalian animals, and also if you look, for instance, these anatomic diagram of a very young fetus. There's a midline cut here. I'll go here and then I'll reverse it because that's the way we look. So here, for instance, is a mammillary body in a very young fetus, let's say 10, 11 weeks. And here's the anterior commissure. And here's this, what's called a massa commissuralis, where all the commissures form. This is where the corpus callosum starts. So it's very close to these structures. And if you look at the reverse here, region of the corpus callosum beginning, the anterior commissure, and the mammillary body. These structures are easy to find, and they're always there. The mammillary body, anterior commissure. So I used that line to study the evolutionary changes in the position of the genu, the embryologic change in the position of the human genu, and also the position of the genu in at least 1,800 MR cases that I looked at that had a normal corpus callosum, and 113 cases of abnormalities. So here's, for instance, the rat brain with the line going from the mammillary body through the anterior commissure. Notice that the anterior end of the corpus callosum is behind that line. The same thing in the rabbit. Line going, the anterior end of the corpus callosum is behind the line. Same thing in the cat. But notice in the dog, there's a little bit of corpus callosum now in front of the line. And definitely in the monkey, we see the beginning of a genu here, which is in front of this line, and also the singular gyrus is starting to curve again because of the development of the genu of the corpus callosum. And notice in the human, marked expansion and kind of the rounding of the genu and way beyond the Mack line. And it's likely that in the animal, which we would call the genu by the anterior end, it's really not a true genu. Eventually it'll be part of the body and the human corpus callosum. And that's what I'm saying here. It's incorporated within the body. The true genu, the human genu, is not present in other animals. I like this statement: what is often more condensed or concealed in one species, nature displays more clearly and openly in another. This is in 1664. That was true in my dissection. It was an eye-opener to look at these brains. Virtual anatomy may be good, but looking at specimen is incredibly valuable. Again, the commissures develop all within, so for instance, anterior commissure being the oldest because its olfactory brain connection is in 9 to 10 weeks, the hippocampal commissure 10 to 11, and the corpus callosum start 11 to 12 weeks. Notice they're all bunched together in the mass commissuralis here, right in front of the upper part of the third ventricle. And again, same thing. These are human specimens with midline sections showing the development of the corpus callosum. So at 12 weeks, here's the Mack line, a rudimentary corpus callosum behind the line. At 16 weeks already, we see a larger corpus callosum, and we can see that the eventual region of the genu is in front. So the progressive enlargement with passage in front. And definitely in a 20-week fetus and a 30-week fetus, notice a much more larger genu in front of the line. So as the fetus ages, the corpus callosum develops and moves anteriorly to form the genu. And here's the clincher on fetal MR on intact specimen. Here's a 13 weeks. Look, a very small corpus callosum behind the line, and at 14 weeks you see a little bit of rudimentary corpus callosum now developing in front of the line, and here's the beginning of the true genu in front of the Mack line. When I looked at the MRs of patients, any patient who had a shunt was excluded from the study because shunting and the perforation of the corpus callosum will damage the corpus callosum, and you end up with various anomalies which we did not want to include in the study. And again, in the 1800 cases, and since that time, many years, the genu of the corpus callosum was always in front of that line. So there was no issue. This was correct. And no abnormal cases did I find where the genu was in place in front of the line and where the anterior body was absent. So the anterior body really formed first and the genu followed. And here's abnormalities. Notice rudimentary corpus callosum behind the Mack line. So in conclusion, the anterior to posterior development of the corpus callosum not supported by phylogenetic analysis, not supported by embryologic analysis, and not supported by MR analysis. That was the end of the story. Corpus callosum first develops in the region of the anterior body and grows bidirectionally. And this was published in AJNR, and it's not been refuted so far. Now, let's move on. One of the things that struck me when I was doing the study for the GENU, that I saw this very thin line here, and I was wondering, what is this line? It's always there, coming out of this rostrum. It was even there on people like, here's a septo-optic dysplasia case, you always see this very thin line. Again, this says the corpus callosum normally develops anterior to posterior direction. Wrong. Lastly, the rostrum. It made no sense to me that the rostrum would be the last. It just was not right. Because it grows in the region of the anterior body and then grows bidirectionally. So again, if we look at the specimens here, so here's the rudimentary corpus callosum in a young human fetus. So it would be in this location here. Why would the rostrum be the last if it's so close where it starts, where the corpus callosum starts? It made no sense. Again, this is where it all starts, and the rostrum is very close. Again, as I showed before. And again, in every case, I saw this very thin line. Even the abnormalities, you would see this very thin line. So again, the rostrum normally is this point, this part of the myelinated corpus callosum, but there's also this kind of little fibrous band, which I saw in MR. So this whole study started because of what I saw in the MR. So this is the thick myelinated portion of the rostrum. Then we have this fibrous little band. Again, this is where I saw it first. Turns out when I went to the literature, this anatomy book by Sabota points out the rostrum and points what he calls the lamina australis. So he says the rostrum passes in front of the commissure, the anterior commissure, and extends the lamina australis to the lamina terminalis. And even Stedman's dictionary talks about the lamina australis, a whitish line appearing in the perfectly median section of the brain as a thin bridge connecting the rostrum of the corpus callosum with the lamina terminalis. So this is what this is. So that's what I was seeing on the MR. The lamina australis connecting the myelinated portion of the rostrum to the region of the lamina terminalis and the anterior commissure. So here it is again. So this is actually the non-myelinated portion of the rostrum, the lamina australis. It tethers the myelinated part to the region of the anterior commissure, lamina terminalis. So I wanted to determine if the rostrum is frequently stayed the last, and also to look at the lamina australis. So again, looked at SPGR images in 300 patients and also in patients with abnormalities. And then I did some dissections. I'll skip over that. So I identified the lamina australis in a large number on these patients' MR. And I'm just showing here dissect the specimen, and again, here's the comparison. I showed this when I was talking about the limbic system. I won't go through that. Again, a little variation here, and a different shape of a rostrum and the Lamina Australis. So again, this is the structure, the Lamina Australis, or the fibrous portion of the rostrum. Now back to the issue of being the last. Look, here's a 14-week-old fetus. Here we see this little band, a rudimentary corpus callosum, and here's this band. So the fetal Lamina Australis is already present prior to the development of the genu. So here's the later 22-week, we see the genu, we see the Lamina Australis, but it's there much earlier, before the genu even formed. So it looks like the corpus callosum is kind of anchored, and because it forms within the hippocampus, it's kind of anchored by the Lamina Australis and the fornix posteriorly. And it's interesting that when I look back, this was a famous book by Retzius from the 19th century. I added the arrows, but he pointed out again the anchoring of the corpus callosum, and he showed these little fiber bands. So this is, again, the Lamina Australis, but although he did not point them out or name them. And this is the clincher. I was excited to see this 5-year-old MR. Look how similar this rudimentary corpus callosum looks to the fetal specimen. Exactly the same. Corpus callosum, the Lamina Australis, the fornix going here towards the lamina terminalis. Looks dead ringer in this 5-year-old to the fetal specimen. And here's another patient at 3 weeks old with coloboma and microphthalmia. Again, a rudimentary corpus callosum. Again, the area of the Lamina Australis, very similar to the fetal specimens. And again, this was always seen even when we only had a rudimentary corpus callosum. It was always there when we only had, for instance, the body. There was also, so it was there. Again, partial corpus callosum, always evidence of a Lamina Australis. So in conclusion, from the earliest stages of development of the corpus callosum appears to be anchored anteriorly by the Lamina Australis and posterior by the fornix. The Lamina Australis segments of the fetal rostrum is already present before the gnu and the spleen develop. The posterior pointed beak segment of the rostrum is likely the result anchoring effect of the Lamina Australis. And the beak segment of rostrum developed concurrently with the maturation of the genu. The shape of the genu suggests that its growth is tethered by the rostrum. So the rostrum is not the last segment of the corpus callosum to develop. Definitely not. It also can be identified in many mammals, some of whom have a genu that is much less developed than the human genu. And again, all this suggests that the rostrum and the Lamina Australis are phylogenetically and embryologically much older than the human genu. And I want to point out that the determination of that the rostrum is not the last part of the corpus callosum to develop could not have been made without outlining. It was really when I saw it on the MR images that started the whole process. So it was quite an amazing how helpful the MR images were in analyzing and putting the rostral development in its true location. And again, this was published again in AJNR in 1997. However, the idea of the front to back growth still persists, unfortunately, in some literature and also in training. And this is the end for today. Thank you for your attention.